Thank you all for being here. Today we're going to be talking about physical health, mental health, substance use, and housing, a prescription for better health. And we have a great panel of speakers here. As many of you know, I'm the co-chair of the Social Policy Committee. I work for a project called Common Ground Santa Barbara County, which is a project of legal aid, where we do homeless outreach with both staff and volunteers. So this is an issue that's of great interest to me. And I think, as many of you know, with the Affordable Care Act and the expansion of Medi-Cal, there were some great opportunities to increase health care across our country, and particularly here in California. And so I know this audience, a lot of people know a lot about health care already, but what is Medi-Cal? Medi-Cal offers free or low-cost health coverage for California residents who meet eligibility requirements. Most applicants who apply through Covered California and enroll in Medi-Cal will receive care through managed care plans. There's no deadline for Medi-Cal. We're actually we are in the open enrollment period for the Affordable Care Covered California, but Medi-Cal has no open enrollment time limitation. How much does Medi-Cal cost? For many individuals who enroll in Medi-Cal, there's no premium, no copayment, and no out-of-pocket cost. And so what's the difference between Medi-Cal and private coverage? Medi-Cal is health coverage, just like the coverage offered through Covered California. Medi-Cal provides benefits similar to the coverage options available through Covered California, but often at lower or no cost. And Medi-Cal, under the expansion, has a lot of essential health benefits that must be included. And I know our panelists will speak more about that, but they include not only outpatient services and emergency services, hospitalization, but also mental health and substance use disorder services, including behavioral health treatment. So as we've discussed in previous forums and pertaining to the work I do, living on the streets long-term is deadly. Studies show that chronically homeless individuals are more vulnerable and 2 to 3 times more likely to succumb to preventable illness than the general population, and their life expectancy is between 42 and 52 years. So these expanded health services offer some great opportunities. I'd like to start by introducing Dr. Wada, the Director of Public Health, who can speak about how things have been going in our county so far with enrolling people in Medi-Cal, what the use and access here in Santa Barbara County looks like. And you can speak from the table or come up to the podium, whichever you prefer.
Okay, I can just speak from here. I think that's fine. So thank you for the introduction. It's great being here again. I know I've spoken to the League of Women's Voters in the past, and it's always a really engaged and informed audience, so I look forward to the discussions today. So when we're talking about healthcare, it's hard not to do that without talking about the Affordable Care Act, because that's had such a big impact on the healthcare landscape. Just as a quick reminder, and I think I've actually done Affordable Care Act presentations here before, but just really quickly, just as background, it was a law that was signed in 2010 by President Obama, and it was meant to increase the number of Americans with health insurance coverage, either through an expansion of Medicaid, and as Emily mentioned, Medicaid, or here in California, that's Medi-Cal, is the coverage for low-income individuals. It does not cover undocumented, which I'll talk about a little bit later. And then it also expanded health insurance coverage through health insurance exchanges. So here in California, that's through Covered California. And that program covers people who aren't in the lowest income bracket for Medicaid or Medi-Cal, but it goes up to 400% of federal poverty level. And then there were a number of other things that the Affordable Care Act implemented, and that was things like allowing dependents to stay on parents' coverage until age 26. They the inability to deny people for pre-existing conditions, no cost preventive services, no lifetime caps, small business tax credits. They closed the Medicare donut hole. So there were a number of other things that were implemented with the Affordable Care Act. But the biggest and probably the one that got most attention and in some instances the most controversy was the insurance mandate. And so that was the requirement that all individuals have health insurance. For those that couldn't afford it, of course, there was the expansion of Medicaid and then the health insurance exchanges. So as I know, again, you're all very well informed, but around the country, there were some states that declined to expand Medicaid. So that created problems in some of those states with big uninsured populations. But here in California, fortunately, the governor and the legislature decided to go ahead with the Medicaid or Medi-Cal expansion. So how has it been going for us? Here in Santa Barbara County and across the state, we've actually exceeded what the initial projections were going to be. So here in Santa Barbara County, again, there are three ways. You could either there were people who qualified for the current or existing or past Medi-Cal program. Then there was the new Medi-Cal program that again covered individuals up to 138% of federal poverty level. And just to put it in context, that's about an income of $16,000 for an individual or $33,000 for a family of four. And then there's the health insurance exchange or covered California, which then went from 138 to 400% of federal poverty level. So that covered people up to about a family of four income of $94,000. And then if you were above that, you had to pay full cost. But again, depending on your income range, there were certain subsidies that were provided. So here in Santa Barbara County, to date, again, this was implemented at the beginning of 2014, so we have now enrolled over 42,000 new individuals into Medi-Cal. And so CenCal, which is the Medi-Cal managed care plan for the county, who enrolls all Medi-Cal for Santa Barbara County, they're now up to 112,000 members. And so if you think about that, that's over a quarter of the population now for Santa Barbara County is now on Medi-Cal. And if you add on to the roughly 60,000 or so that are Medicare, you're talking about almost half our population on some type of public health insurance. So that's a big part of our healthcare landscape here in Santa Barbara County and across the country. And because of that, Medi-Cal and Medicare, as the primary funders of insurance, can actually drive a lot of innovation and changes in how we do business. And so there are still probably another 8,000 to 10,000 individuals out in our communities that are eligible for Medi-Cal but aren't yet enrolled for various reasons. And a lot of us and nonprofits have been working on trying to get those individuals enrolled and into Medi-Cal so that they have that comprehensive coverage package. But it's really been a great community effort. So as I mentioned, we've now enrolled over 42,000. Initially, we did a lot of planning with all the stakeholders and all the other agencies. And for Santa Barbara County at this time, we thought we would have about 25,000. So we've gone way over our projections. Just within the public health department, we've seen our patient population go from 13,000 Medi-Cal to now 23,000, almost 24,000 Medi-Cal. So of that 40,000 new Medi-Cal, the public health department alone took in about a quarter of that. So the public health department, we run our own clinics all the way from Carpinteria all the way to North County and Santa Maria, and we're the biggest Medi-Cal provider in the county. And so we provide a lot of those services as well as services to the uninsured. And as I mentioned, as Medi-Cal expanded, they also, as part of the Affordable Care Act, really tried to drive us in a certain direction in terms of how we provide that care, and they provided a lot of different incentives and grant funding to do that. So one obviously was just to make sure we had enough capacity locally to take on this new population. A lot of the individuals were uninsured previously, and they were already in our system receiving some level of care, so I can't say that all these are just new people piled on top of our existing patient population. A lot of them just converted within our system from uninsured to Medi-Cal. Which certainly helped our revenue. But there's still a big need for expansion because there's not enough primary care. So unlike Medicare, where a lot of our community providers will accept Medicare patients because the reimbursements are reasonable, a lot of our community providers don't accept Medi-Cal, a lot of our private doctors. And so that's why it's left to a lot of the community clinics and nonprofits to take up that population. So within the public health department, we are looking at expansion projects in each of our healthcare centers, all the way again from Carpinteria to North County. We're doing remodels to increase the number of exam rooms and try to bring on new staff providers and physicians to accommodate and see these new individuals. There's also a big move towards something called patient-centered care model. Patient-centered medical home model. And so this is a sort of a new model of healthcare operations and delivery where it's much more sort of team-based and holistic. You have an assigned medical provider who coordinates all that care, but again, we work in teams with pharmacists, with a nutritionist, with dietitians, and also a big push towards integration, so trying to bring in behavioral health care and substance abuse into the primary care setting. And so these are things that we're trying to do within our healthcare centers. And then, again, just an expanded need for capacity, and that's something that I think is affecting a lot of us. So we're looking at sort of future issues and opportunities related to the Affordable Care Act. There are other future Medi-Cal expansion issues that are out there. And so one here in California that has already been passed is that they're going to expand Medi-Cal to cover undocumented children. So that's another big population that's going to come into Medi-Cal and have a number of effects here within the county. There are also some proposals to expand Medi-Cal to cover undocumented adults. That hasn't been passed yet. That's still sort of under consideration, but that's another thing that the state is looking at. There are other expansions related to substance use disorders and again behavioral health, and so making sure that there's equity there and that those services are covered and part of the base benefit package, and also looking at dental. So there are already some expansions related to covering dental for children and adults, and they're looking at that further. So again, those are some big areas where Medi-Cal is looking to expand to better take care of our patient population. Because as you know, when people are uninsured, they either don't seek care or they delay seeking care. And so when they ultimately get into the system, their diagnoses and their level of disease burden is so far advanced that then it's more costly to treat. So I think the state and the policymakers have finally realized that we need to get these people covered, get them access, get them preventive care, treat their illnesses and diagnose them at an earlier stage, and it's actually going to save the state down the road. It may be a little more costly up front, but in the long term, it's better for our population, better for our communities as a whole. So that's really the way that the state and the federal government is going. There's also, again, a big push towards integration of care. And so instead of having a fragmented system where a patient goes to one place for their primary care, they have to go on a different day for mental health, and then a different place for substance abuse, and then their dental's over here, not even covered. We're really trying to bring that all together, make it more of a seamless type of a system, or at least if you do have to refer out, that it's better coordinated. There's some big push also on the health information side of things, where people are getting onto electronic health records that are going to be able to communicate that data across providers much easier. So that's something that we're upgrading within the county. I know that Cottage and a number of other hospitals and community clinics are also doing that. In the past, when one of our patients would end up in the hospital or the emergency department wouldn't know what the diagnoses were, wouldn't know what recent tests were done, wouldn't know what medications, and if it was somebody who didn't recall that information, there was a lot of duplication, a lot of medical errors that would happen. Prescriptions would get prescribed that conflict with something else. So now that we have a more coordinated way of exchanging information, that should certainly help our healthcare system. And then there are also some movements in terms of Medi-Cal or Medicaid covering housing, or at least assisted living. And so in the past, again, these were not services that were covered. But as Emily mentioned in her opening, I think there's a recognition that housing is a huge component in terms of health care and if people are going to be compliant. And so, in the past, sort of the medical model was, these individuals wouldn't have any insurance. They'd show up, they'd get, diagnosed, they'd get a treatment, and then they'd go back out on the streets. And how do you expect somebody then to be able to take care of themselves or post-hospital care or get the preventive care that they need? Or there are all these other social determinants of health that were not being addressed, and that would impact their ultimate health care. So Medi-Cal is looking at ways to, again, be more holistic and look at covering assisted living. Unfortunately, the state rolled this out as a pilot program, and they selected only a few counties to participate at first, and Santa Barbara County is not one of them. But it is in some of the bigger counties in California, and we're hoping that at some point they'll roll it out to all counties. They're, again, looking at other housing options. And then there's some counties that are doing some things that are a little bit more innovative. So Los Angeles County has a new program called Housing for Health that's being funded at the local level, where they're actually paying for housing because they've realized that, again, by doing that and giving people stable housing, it's actually reducing impact and usage on emergency departments and on incarceration and people getting into the legal justice system. And it's actually saving globally dollars by providing that housing. So these are things that some counties are looking at. I know we've had a lot of discussions about things to do here in Santa Barbara County, but there are a number of things. And then looking at some of the potential risks related to the Affordable Care Act. The first several years of the Affordable Care Act for this newly expanded Medi-Cal population is fully funded by the federal government, but that's going to start phasing down. So it goes from 100% to 95% to 93, 92, and down to 90% federal coverage. And so the state has to figure out how they're going to make up that difference. And the state hasn't figured out how they're going to do that yet. So we have some concerns that they're going to try to reach down into counties to try to make up some of that difference. But that hasn't been determined yet, but that is certainly a risk. There are other things that are on the table. You mentioned some propositions. I know there's a tobacco tax that's likely going to be on the ballot coming up that will help fund that gap so that we don't have to have any impacts to our services. There's also a big issue at the state called the managed care tax, or the MCO tax, that hasn't been resolved yet. And if they can't resolve it, it's going to be another $1 billion or $2 billion hit to the state. So they need to figure that one out. And then there's political uncertainties as well. And so, with the Affordable Care Act, if there's a change at the federal level in terms of the president or Congress or with the Supreme Court, you never know, which way things are going to go and what the ultimate fate of the Affordable Care Act is going to be. So, for us with the county, we're supposed to be sort of apolitical, and we just kind of take what's given to us and try to make the most of it and maximize the benefit for our residents here in Santa Barbara County. So I can't really weigh in on one way or the other, but that's sort of where we are now, and we're always just kind of looking at ways to make things more efficient, more effective for us here in the county. So I don't know if we're taking questions now, or do I pass it on to the other speakers?
Do some questions now. Questions?
Please wait till you have a microphone before uttering your
Okay.
Gene, here you go. Have one for Gene.
I think I've read that the federal government doesn't contribute any money towards medical care for undocumented people. Does that mean that the undocumented children that California is now going to cover, that it's going to be completely at the expense of the state?
That is correct. So with the Affordable Care Act, it does not cover the undocumented. So the Medi-Cal expansion that the state is going to implement to cover the children is going to be state funded. Yeah, now I should mention though, here in Santa Barbara County, we do locally fund what's called the Healthy Kids Program, which allows the undocumented to participate. So there's already a local program that can be used to cover the undocumented children. And then also, if you're a federally qualified health center like we are with the county, we get certain benefits in terms of our reimbursement, but we also can't ask about immigration status. And so if you're undocumented, you can still come into our clinics and receive care. We don't ask, and that care is going to be subsidized. And so, yeah, you're correct, the Affordable Care Act doesn't cover the undocumented, but there are a number of settings within the county that will see the undocumented and provide that care.
Is Healthy Kids going to continue? Does it last beyond just this year, next?
Assuming that the state rollout of coverage for undocumented goes as planned, which is a rollout in the spring of 2016. The Healthy Kids program will be phased out probably over the summer. So there's certainly going to be a transition because the individuals who are in Healthy Kids who are undocumented, or for them to switch over to Medi-Cal, you still have to go through the regular eligibility and enrollment process, provide your whatever papers and things like that for income. And so there's going to be a transition there, but you're right. If it goes forward that way, then the Healthy Kids program won't really need to exist, and so it's scheduled to be phased out over the course of 2016.
And that's because of this bill, but is it going to continue in other states? The federal government is going to continue with the Healthy Kids program?
The Healthy Kids program is not a federal program. So it's actually a local program. So it's county by county in California. So some counties have a Healthy Kids program, like Santa Barbara. Other counties don't have one. And so we here in Santa Barbara County used to have one of the highest rates of uninsured children in the state, which was why we decided to implement a Healthy Kids program and then fund it locally. So it's funded actually through county dollars and through some other revenue sources. First five, tobacco tax dollars, and things like that.
I've seen a lot of good changes with the mental health side at ADMHS with CARES and beefing up peer support and all that kind of stuff. I think you guys have done a great job. But my question is on the side of substance abuse and being more proactive in giving clients tools, things like Vivitrol, naltrexone, things that will help curb their urges instead of just social model recovery. I'm wondering if there's anything on the radar for that.
I might leave that to the ADMHS person, but I do know that there's been some movement on naltrexone and Suboxone, but maybe Kuko can
and I'm going to be
respond.
talking a little bit about that because I think that, and my name is Refugio Rodriguez, I work with ADMHS, and I do intend to talk about, I think, two areas of opportunity, and that certainly is one of them. Because, ACA, I think, it did wonderful in terms of providing access to populations that previously didn't qualify for benefits. But what I think we forget sometimes is that ACA also provided the opportunity to create additional services that were not previously covered, specifically in the mild to moderate area. And that's beyond kind of what we are mandated to provide. And then the other area is coverage on the alcohol drug side for medications like Suboxone, Vivitrol, that were not previously covered by Medi-Cal. So prior to ACA, if you had the resources, you could access those through your primary care or other folks. I mean, obviously there's a certification requirement, those things. But if you were a Medi-Cal client receiving alcohol drug services, the only option you really had was methadone. And, in many cases, we have clients that are on methadone for 10, 20, 30 years, the rest of their life. And here you have now an option in every county here in California where we can provide alternative treatments and they're not covered. The issue is that counties, and that's why I said it's an opportunity, how do we maximize because I think every county is facing this challenge, and as Dr. Wada talked about, just the huge influx of clients that are coming in is a big impact to our systems. But in addition, the infrastructure that we have, is it prepared to expand into these areas? These are all innovative things that some counties are doing and others are having struggles with. So I will talk a little bit about that. There are some discussions around that, but I think overall, counties across the state are struggling with that coordination of the multiple providers, because it's, although we're talking about health care, it's health care in a very broad term, and our systems haven't really operated that way before. I don't know if that helped.
Any other questions before we move on? I think that's, so I was actually going to announce Cuco Rodriguez next, because another department that's obviously been county department that's been impacted significantly by the Affordable Care Act and the Medi-Cal expansion is our alcohol, drug, and mental health services. So you're welcome to come up or to stay at the table, but Cuco is the division chief for the Mental Health Service Act, Prop 63, which League supported way back when that was passed, which was a tax that increased revenue for mental health services in our state. And he also I've been able to work with him on doing cultural competency trainings, and so he can talk, I think, also about the access issues for people, so that all people in our county are accessing some of these new, Medi-Cal benefits. Thank you.
Okay, thank you. Again, my name is Refugio Rodriguez, or Cuco, is how I usually go by. And I am the MHSA Division Chief for ADMHS. I'm also the Cultural Competency Manager. And because I didn't have enough to do, they also assigned me the implementation of the Affordable Care Act for our department. So, and I work with Public Health and DSS. On our end, and I'm going to talk a little bit about the Affordable Care Act. And I mention these roles because I also have to mention the cultural competency side, and because that's, again, a major focus for the work that I do, and also the implications that ACA has on particular populations that have traditionally not had access. And that goes in terms of our department, but also just across our community. In terms of ACA, the Affordable Care Act, our focus clearly was not as broad as access to health, even though it did have those implications. But for us, we really were looking at those populations that were receiving alcohol, drug, or mental health services in our department who qualified for benefits, but were not receiving them. So we kind of embarked on a process in the first year and even through now, but really major focus in the first year on trying to identify and enroll as many people as we could who qualified for benefits. And again, in partnership with all the other county entities, because everybody was kind of doing their part to enroll people. So in the first year, we probably enrolled about 1,700 people that were receiving alcohol or drug services or mental health services in our department in the first fiscal year. About 1,000 of those were specifically mental health, and then about 700 of those were probably an alcohol drug. And then the total projected revenue for the enrollment of those people was about $5 million. So you can imagine the impact that would have on our department without benefits, just to give you kind of an idea. And again, this may be people, and these are projected revenues, they're not necessarily actuals, but at the same time, it gives you an idea of the sheer magnitude of services that are provided. And then again, some of these folks might be ongoing long-term clients, or some of these may just be accessing our crisis services or some other services. But nonetheless, through that process and in partnership with the other county entities, there were about 1,700 clients just in that first year that were enrolled in Medi-Cal. And then again, we also had a significant effort in working with Emily and other partners on specifically targeting also our homeless populations, who again were very disproportionately uninsured and had, again, qualified for benefits. So I think through all of that work, we were able to qualify quite a few people. And again, it continues it is an ongoing effort. In terms of ADMHS, you know, our funding categories, I mention this because ACA is a significant part of this. You know, we have our funding streams really vary in terms of, they're not significant, but it's county general fund, Medi-Cal, grants, and then the MHSA component, which is Prop 63. Those really are our funding mechanisms. And I mention that because ACA created some additional opportunities in terms of resources. And then within the last 2 years, and actually Dr. Wada was our interim director at the time, our department made a significant shift in terms of its focus and how we prioritize funding. Medi-Cal clearly has some limitations in terms of reimbursement and services to people who are undocumented, but the Mental Health Services Act does not. And I think under Dr. Wada's leadership and under Dr. Gleghorn's leadership, one of the significant shifts that we made in our department was to prioritize funding so that we could cover those services for people who did not have coverage and utilize some of the MHSA resource to do so. Because at the end of the day, we are really the service of last resort when people go into crisis or are needing mental health services. And prior to probably 2 years ago, the position of the department and the policy of the department was that we would afford services to people who were uninsured, but only if there were resources available. When in reality, we always kind of had resources that were really, that would allow us to do so if they had the latitude. So within the last 2 years, that's been a significant shift. And again, we also have a significant shift in terms of focus where services really are determined by clinical necessity and not by an individual's ability to pay. So in some ways, we were kind of ahead of the curve. And that was a very important change, I think, especially for communities who already had a perception that we didn't provide services because of their residential status. And again, I think Dr. Wada talked a little bit about Senate Bill 75. I was actually on a conference call yesterday regarding that because that will afford, again, full scope Medi-Cal to individuals 0 to 19 if they meet the financial eligibility requirements. But again, this would be for undocumented populations. And again, that's going to have a significant impact for us because we do serve a significant number of young people who are undocumented. But I also like to point out to people that, you know, who we have in our system is but one group. There are 3 or 4 times that size in terms of populations that we're not serving because of perception or because of fear of deportation or other issues. So again, I would assume that that number will grow as we kind of expand coverage, not only on the mental health side, but also on the public health side. In terms of, you know, looking forward, one of the things that Emily had asked was to talk a little bit about looking forward in terms of opportunities, and I think I talked a little bit about them. To me, what was significant about the Affordable Care Act was that it, you know, prior to ACA, if you didn't meet criteria for our system, and by criteria, I mean that somebody has to be seriously mentally ill. And there are a lot of people who are not seriously mentally ill. Who have what we now term in ACA as mild to moderate mental health issues. And ACA created a whole kind of strata of services, which is what CenCal covers, and it's really, I think right now, administered through the Holman Group. So that's, I think, a very significant service that is covered through Medi-Cal that previously was not. Because again, prior to ACA, that really didn't exist. It existed in maybe some loose form in terms of our provider network and so forth, but that was very highly specialized. Under ACA, this is now an added benefit that didn't exist. So I think that that should have significant impact in terms as we move forward on populations, in terms of prevention, when we look at preventative services, because again, these would be folks that don't meet criteria for our system. And I think that our challenge as a county, I think, and as well as other counties throughout the state, is really how do we maximize the opportunities that ACA is affording us. And I think that's a significant one. And I think in our county, I think Holman is doing the best it can. But I think that we might benefit from looking at other counties and looking at models where they have opened up opportunities and access, and looking at models like Dr. Wada talked about, where people are identified in primary care settings and they receive their mild to moderate or even their other mental health issues in the same location, instead of having to be referred to one place and then go to another. And I think that right now, by increasing that access to people in the mild to moderate category, I think that we'll see significant impacts in our communities on the prevention side. And similarly on the alcohol drug side, the added benefits and coverage in terms of treatment for specifically, especially for opioid dependency, I think those are significant opportunities that we really should maximize as a county. Other counties are struggling with the same thing, again, because this is a new area for us. This is really emerging of, the public health and the alcohol drug side and the mental health side, because many of our clients who have alcohol and drug issues also have mental health issues. So I think this is a significant opportunity. I think that ACA, to the extent possible, created the infrastructure for us to be successful and have significant impacts in communities. But I think the challenge now is for our county departments and everybody involved, including the community, to work together to kind of maximize those benefits that now exist and the coverage that's available. Because at the end of the day, I think that that's what our departments are about. So with that, I will open it up if anybody has any questions.
Perhaps Anne Marie will address this, but Kuko, I was wondering if you could talk a little bit about what opportunities there are to address the mental health issues of homeless people on the streets, as a result of what this mild to moderate program you were talking about, or the Holman Group, or anything else. Is there any effort going on, and are there potentials to actually do something with this group?
Yeah, well, and I think in the last probably 4 or 5 years, I mean, we certainly see a large number of partnerships. I mean, that's how I met Emily, and I think that's a perfect example of where all of the providers kind of have to come together. Existing partnerships do involve public health, mental health, alcohol, drug, housing, developers. I do some of the housing as well for the Mental Health Services Act, and I can tell you that, the housing development side is a whole other, I can talk social services and access and those types of things all day long, but the development side is just a whole other arena. And if you want to talk about bringing in partnerships that I think traditionally you didn't see, that's really the area. And it really, I think, points to the fact that the models that we develop in terms of services, I think really, and ACA kind of does that, begin with the population that you're serving. If you start with homeless populations, you see that all these other different departments that are attached and have to be at the table, and that's where your coordinated efforts. We are beginning to see a lot of that work being done with the Vulnerability Index and some of the partnerships around services to homeless populations, but I think that the very critical component is housing. We can provide health care, we can provide dental care, we can provide all of these things, but if people are not housed, it becomes a challenge to even find people. And we have expanded on the mental health side, our homeless outreach teams and so forth, but I think that, we can't get around that big elephant in the room, which is housing. And not only for our homeless populations, housing across this county in general. So.
How about a hypothetical that's pretty common? If you have parents that are seeing their teenage kid become addicted to something, meth or heroin or whatever, what would they do to try to get help?
Well, I guess, certainly I can give you our access number for alcohol, drug, but, my work actually prior to coming to alcohol, drug, I worked for 12 years with nonprofit agencies, and my particular focus was with gang-involved kids and kids who were incarcerated. And typically, they were not incarcerated because of other behaviors. A lot of it was alcohol, drug-related. There were some violence issues, obviously, but I can clearly tell you that I think as having worked for so long there, I think and the reason I talked about the mild to moderate piece is that, I really believe in prevention. And again, prior to ACA, we didn't have a system that provided mild to moderate care. And we do now. We're just limited by our capacity. There's no capitation in terms of the type of services that we provide. Certainly there's limits in terms of the amount of sessions and so forth, but certainly it is a preventative strategy that we did not have. And I think that the more investments we put in terms of prevention, the more opportunity it creates, not only in mental health, in every part of the services that we provide. Our department has shifted its focus to looking at crisis services and so forth, and that was a really great change because it's looking at front-end investments and not hospitalization or looking at alternatives to hospitalization. I think in terms of alcohol, drug, and I think in terms of other issues, because I don't think it's just alcohol, drugs. I think that that's a symptom of a bigger issue. And yes, it's manifested and certainly is very dangerous. But typically with kids that we've worked with that have those issues, there's other issues. And even if I take care of the alcohol drug issue and I save their life, I did pregnancy prevention, HIV work. There was no point to the work that I did because if they walked up the street and got shot and killed, did I really make a change? Did I really make a difference? And I couldn't just say, well, I'm not going to address that particular part of you. I'm here just to deal with your alcohol drug issue. No, I had to address the whole compendium of things. So I think that there's some opportunities with ACA. We're looking at housing. I think it's a wonderful direction, but I think it's really what can we create so there are those opportunities for families to call. And yeah, we have providers that can try to address that, but I really don't know if as a partnership or as a community we really developed enough of the prevention aspect of things, especially with males. We're very good at working with males when we do stuff wrong. We're not that great at doing voluntary interventions. We're good at mandating them to go to things. But I don't know if other folks want to add.
Well, I have a different kind of question because listening to what you and Dr. Wada have said, it occurs to me that the states that elected not to go with affordable care must have lost a lot of ground. At least they haven't gained any ground as California is doing. It certainly sounds like that's a serious loss for any state that decides not to have it.
Correct.
I didn't hear a question. That was just a good statement.
Are we talking about expansion of Medi-Cal here? Because states went with Affordable Care Act, Medicaid.
Yeah, I think Dr. Wada pointed out that there's some states that just opted out of ACA. I mean, and that's and I think if you go on the news or even online, you'll see a lot of documentaries of people that are negatively affected. Where else in this country? I guess any politician would forego to bring in benefits to your community that you're supposed to represent. But there's multiple, I think 23 states or something like that have foregone benefits, access to health care and other services.
Emily, there's a question over here.
Sure.
Kuko, you mentioned that the Mental Health Services Act provides funding for housing. Can you elaborate on what kind of funding is available, what you'd be looking for in terms of community partnerships, and what can we do? What opportunities do we have here to create housing?
Yeah, well, the Mental Health Services Act was approved in 2004 by a lot of you probably, hopefully voted for it. It's a 1% tax on anyone making over $1 million. And that actually created a significant amount of revenue for counties. Each county gets a different allocation based on population, prevalence, a lot of these other things. It's a very complex formula. But each county gets its allocation, and each county also gets its allocation by particular area. Some of those areas are ongoing, so our largest component, which is community service supports, which would be a lot of our ACT teams around the community and supported housing teams, those are funded through that component. Prevention, early intervention is another component that's also ongoing. And then the third component is called innovations. And again, that is an ongoing component. There were particular components or allocations that we received that were only one-time allocations, and one of those was housing. In our county, we received $4.5 million for housing. We actually still have about half of that funding left because we were able to develop wonderful partnerships with developers who actually, we would provide the initial investment, they were able to leverage other funding, and then they'd give us the money back. So in Santa Barbara County, we have about $2.3 million left specifically for housing. Now, the parameters around this is that we have to partner in certain projects. A certain proportion of units have to be, for mental health clients. They have to be units specifically for long-term housing. Stable housing for clients. And they also have to include service components. So I think a lot of you are familiar with all of this. A lot of the housing models that we're looking at for homeless fall into this category. Across the county, I don't think people realize, we have funded about 46 units specifically for clients who receive mental health services. At Garden Street, we have, I believe, 10 units. We have in Lompoc, we have another 14 units. These are single units. And then in Santa Maria, we're one of the first counties that actually funded 2-bedroom, 3-bedroom, and 1-bedroom units for mental health clients and their families. Because again, looking at it from a cultural competency standpoint, not all of our clients are single white males between the age of 50 and 60. Okay? We have children in our system, and MHSA was intended to serve that, so that's why we created that. We are working on another project right now in Santa Maria, again, 40 units as well. And then Pescadero Lofts, which opened in Isla Vista, which is, although ADMHS has 12 units allocated specifically for mental health clients, I would say that the majority of those units, which is about 34 units, are all for certainly homeless clients, and probably the majority of those would be mental health clients. So there are some parameters in terms of the use of funds, how we use them. There's also a shelf life that we have to use them, or else we have to revert, and we intend not to do that. But in our county, like I said, we've been able to develop about almost 50 units. We have one of the lowest cost per unit costs compared to any other county. Santa Clara, for example, their range is between $120,000 and $250,000 per unit. Santa Cruz, Monterey, we're at about $40,000 per unit, so we've been able to maximize that. But again, to your question, it is to create long-term sustainable housing, but typically there are some parameters on how we can use that.
You just spoke about how you were looking towards increasing the housing. I have a question. Can you tell us a couple of other specific steps that you plan to take to maximize the benefits?
For Affordable Care Act or for housing?
No, this is in regard to your general discussion, at the end of which you said that for the future you needed to maximize the benefits of the ACA, and I just wondered, that was very specific, if you have a couple more specific examples.
Well, I don't know, maybe Dr. Wada has some. I talked about those two things because they really pertain to alcohol, drug, or mental health services. And then on the prevention side, I think that those are, again, opportunities. But I think that if we look at ACA and Medi-Cal 2 years ago and what's now covered under ACA, to me, that is what gives you an idea of what the potential is, because there's significant changes, not only in terms of access for people that didn't qualify, but in terms of the added benefits that are now afforded to people who are on Medi-Cal. So I think that those, to me, those would be the opportunities. I mentioned those two specifically because those kind of pertain to my arena. I think, again, the other big area is access to populations who traditionally have not accessed mental health services, and those are communities of color. We still have a long way to go in that area.
Yeah, maybe I could just add in terms of sort of maximizing the benefits of the Affordable Care Act. One would be to make sure everyone who's eligible is enrolled. So there's still a lot of people, target populations, whether it's homeless or racial ethnic groups that haven't fully enrolled and taken advantage of those benefits. And then two, making sure people know how to use those benefits and what's actually available to them, because a lot of times people get the insurance and they just don't take full advantage of the preventive care or some of the other benefits. And then they end up still going to the emergency room as their primary source of care. So we have to make sure we educate people. And then some of the drivers of, again, integration and improving quality and health information, I think that will help the overall Medi-Cal population. And then we have to try to be more innovative or creative. And so with some of these housing options, again, it's not enough to just build the housing, but we have to make sure they're retained in that housing, because that's often a challenge. And so looking at using the new Medi-Cal coverage to help pay for treatment or wraparound services at those sites. And so instead of having to wait for these people to come into our clinics, going out to them more and providing the care out in the community, so it's more accessible, and trying to reduce some of those barriers.
I just want to take a little credit here. I'm on the Board of Commissioners of the County Housing Authority, which has built most of those units that you were referring to, and for whom $2.9 million.
And we're very grateful that you continue to partner with us.
Right. $2.9 million for us is a drop in the bucket, because housing is very expensive, land is very expensive, and it's a dance to build anything. It's grants from in one case we had 9 different agencies involved in the financing of a housing project. So, we do the best we can, but it isn't only money, or at least we have to get the money from different places. And the county money, the money you referred to, I think, has been used primarily to contract with providers. We own the housing, so we contract with providers for the services that the residents need. And we've so far been very successful at Pescadero Lofts, and I believe in the complex in Lompoc. We have a minimal turnover rate after a year or more, which is very unusual for these sorts of projects. So I think you guys are doing your job, and we're doing our job. And if the governor realized that we need more money for housing, we'd do an even better job.
Hi, let me just follow up again. Mickey, you're doing good work there. Did I hear you say that your average cost per unit was like $40,000?
To build.
That's pretty amazing in Santa Barbara.
Well, and I think part of the credit goes back to the housing authority of the County of Santa Barbara, because in many cases we had initial investments of units, and they were able to leverage other funding, specifically around Section 8, and other developers that are for profit. I was in LA at a housing conference, and one of the biggest developers says, "Hey, we'd like to come to Santa Barbara." I said, if you can beat our existing partner in terms of cost, not a problem. "Oh yeah, we can match everybody." I said, "Well, they give us money back. We paid $0 for our units." And they're like, "How do they do that?" I said, "They're a nonprofit." And so for private developers, they will keep that money and they put it in reserve so that if down the road there's additional costs, that's where they pull it out of. And it's legitimate. We've been fortunate that the Housing Authority has given us that money back so that we can reinvest in new partnerships. And the other thing that I want to mention is that, what's really great about, if you think back to Housing Authority, 6 years ago, we started our first kind of partnership, or 7 years ago, around mental health clients, and it was a dance. They were like, well, I don't know if we want to provide, this is a different population, we'll do integrated. And then, within 5 or 6 years, they put together Pescadero Lofts on their own. And I think that speaks a lot to the importance of partnerships and really working together and really providing that. The project that we're talking about in Santa Maria now, we are now evolving to look at what we've learned over the 3 or 4 projects, which is, can we have mental health services on site? And not just one person. I mean, we want a fully functional kind of service site, clinic, or program on site. Why wouldn't we do that? So we're evolving in terms of our own partnerships and what we're learning. But it is a dance, and it's also important that we're learning about housing development rules and requirements, and they're learning about our realities in terms of mental health clients as well. So, thank you.
So we would like to take a 5-minute break now so that you can grab some tea or other beverages, and then we'll come back and we'll hear from our remaining speakers. Okay, so next I'd like to introduce Anne Marie Cameron with the Mental Wellness Center. And I've been fortunate to work with the Mental Wellness Center with a lot of the individuals I work with. They have a great day program there, and they also do mental health first aid training, which our staff and volunteers all do that training, and I recommend it to everybody here. It's open to the public. Anne Marie can tell you a little bit more about that. But I'm going to introduce her next after ADMHS because they've been recently partnering with ADMHS on some of the crisis housing piece. So, welcome.
Okay, thank you. When I walked in today, I felt right at home. Many of you have familiar faces, and I was talking to Connie, and she said, make sure and remind people that we used to be the Mental Health Association, and that's how many people still know us. But in 2012, we changed our name to the Mental Wellness Center, and we did it because we'd moved into our new building, and for a couple of reasons. One is we wanted to have a name change and a game change. We wanted to tell the community that what everyone wants is mental wellness, not treatment for their mental illness. They want to get better, and that's everyone, not just people who are in crisis. And so we have changed our priorities to serving the whole community. We've always had that policy, but we became, I think, rather, I hate the word lazy, but we became dependent on working with clients that were in the county mental health system, and we had lost our commitment to serving the whole community. And the other thing is that we made a conscious decision to go forward, and from that moment on, prioritize hiring people who have lived experience with mental illness in our workforce. So now that over 50% of the people who work at the Mental Wellness Center have personal lived experience with the illness, and therefore we have a much more informed and diverse group of people serving our community. I wanted to talk quickly about how healthcare for us is really about housing and our social service programs, but it's also about education. And when I orient a new board member or someone, I tell people that we're a mile wide and an inch deep. We have a lot of little programs that touch a lot of people in the community, and my goal is one day for them to be a mile deep, but they're not too big yet. Our housing program started over 30 years ago when board members back then, before I joined the organization, decided they wanted to model for the community how easy and how affordable it was to start a licensed board and care for people with mental illness. Well, turns out it wasn't easy and it wasn't affordable. So not a lot of people did it. But back then there were a network of about 15 or so board and care homes. Some of them were licensed and some of them were room and boards. And of course, that's when we had all the SROs and all of that. So housing was not as tight. So we've had this board and care over off of Milpa Street on Juana Maria Avenue, a little one-block street. for 30 years, and it's operated without incident, blends into the community. Our clients thrive and do well there. 20 years ago, we opened an apartment complex on Cannon Bernardino across from the high school, and that apartment complex is affordable housing for people who live independently. Because they're two-bedroom units, we have converted most of them to be for families, and we take people right off the vulnerability list working with Transition House if the child or the parent has a mental health disability. 8 years ago, we opened our Garden Street Apartments at our new beautiful building on Garden Street and added 51 apartments to the housing stock of Santa Barbara, and I want to just attest to the complexity and the challenge of using housing funds. It's worth it, but it's a big job and very, very complicated. And then just this last month, we've opened one house, and we are yet to open one other before the end of the year, working again with ADMHS to serve people who have very specific needs. One house is for people who are found incompetent to stand trial by the courts, and they no longer need hospitalization. They can be treated in the community, and they were spending months and months in the PUF, the psychiatric health facility, to the tune of $1,800 a day or so. Our house is far lower than that. And the other house will be a house for people who are on conservatorship or otherwise would go to a hospital. But I say all that, and it sounds like a lot, but the waiting list for the Garden Street Apartments has over 200 people on it, and we get calls every week, people saying, you know, how do I get my child or myself on that list? And the turnover is very low, so it's disheartening to tell them, you know, we ask them to fill out the paperwork and then they have to wait. The Fellowship Club is one of our crown jewel programs. It's been a part of our organization since the 1950s, when family members would bring their loved one home from Camarillo State Hospital or other state hospitals, and they would have this person in their home, and they didn't know how to help them get back into the community. And the Fellowship Club used to be, and I will willingly admit this, sort of a maternal approach to here, we'll help you, we'll take care of you. But it is completely transformed to a peer-run, peer organization where recovery happens every day. We have about 375 members. On any given day, especially towards the end of the month when people's SSI checks have run out, we may have as many as 90 to 100 people who come to the club. Over a third of those are homeless individuals, and that program has a lot of practical applications. We not only serve a hot lunch, we have a care closet, which is an on-site thrift store that we're always needing both male and female clothing for. We have a computer lab where people can access the internet for more than an hour or so that they can get at the library. And we have a music room and an art room and all these wonderful things. And it's the only rule of the Fellowship Club is that you have to be working on your mental health recovery and you have to be kind to others. Everything else is negotiable. So I think it's one of the few places in Santa Barbara. There are other communities like it in northern part of the county where people with their symptoms feel at ease to be amongst friends, and that's an important part of our community. We've had a long-standing partnership with the National Alliance on Mental Illness, the family organization. They are our partners in our public policy effort, and I just want to make a pitch. I was also telling Connie that we have a revitalized public policy committee that's been meeting for a couple of years now, and they're always looking for new members to come join us and become educated about what's going on at the state and national level as well as local. But for me, the most important thing that we can do in healthcare is try to save money by some of this expansion and invest it in early intervention. I feel almost embarrassed as a participant in the mental health world for the last 25, 30 years to only have just realized that we weren't seeing people at our center until they were in their 30s and 40s when they'd had their illness in their teens and 20s. And, we waited for people to find us through the crisis services or the jails or the hospitals. And sure, stigma's still there, so you know, people aren't going to come looking for you, but we need to be doing a better job as a community in reaching people much sooner. So we've luckily this year received some funding from the Women's Fund to do education and support groups for parents of teens and young adults. We're working with the mental health department on supporting young people with mental health needs socially, and also with schools. Education is key. We start at the 6th grade. We have a 6th grade curriculum where we teach 5 days of mental health education. It's an all-volunteer program, almost all retired teachers who do this. And this year we're going into 22 6th grade classrooms, reaching over 600 6th graders, teaching them about mental illness. And it's done in such a way that it supports the Common Core state standards, and it's for language arts, so it's something that teachers welcome. And it's also very matter-of-fact and factual-based information. It's not sugar-coated and it's not dumbed down for 12 and 13-year-olds. They're at the age where they really can handle and understand complicated and complex topics, and we get the best questions and feedback from these young people. It's really amazing. So I have 3 pitches, the 3 things that I think that we all need to be thinking about. One is that in terms of affordable housing, but since we don't have the redevelopment agency anymore and those dollars to invest in housing, we have to think of other strategies. And I know that I'm one of the lucky ones that 20 years ago was able to, with my husband, buy a house and have a house here. But all of my employees, many of them, live far away or they rent. So I think the window is closing on the people that have the appreciated real estate that they can leave to nonprofit organizations. And I'm not suggesting that you leave it to the Mental Wellness Center. I'm just saying that thinking about that investment in the future is key, because those are the last few big game-changing kinds of investments you can make in our community to allow for affordable housing projects to be built. And I'll give you an example. We did have bequest last year, a house close to Cottage Hospital. We were all excited. We thought we were going to start a new housing program. But my board, I have more CPAs than social workers, they said, no, we're going to sell it. And they were right. We sold it. But with the money from that house, we were able to pay off another loan so that now we have no debt service and we can reinvest those dollars in services. And we had money left over that now my board is looking for another housing project. So it's just an example. Those dollars that nonprofit developers get can be leveraged to get $10 for the $1 of donation. The second thing is to encourage young people to choose mental health as their career. We have such a shortage of qualified workers and people who want to do all aspects of this work. And there will be jobs waiting for them when they're done with their schooling. You can almost guarantee it. And it's very exciting and satisfying work. And then the last thing that I wanted to say is that for myself, anyone that you know that's struggling, they have a family member that's looking for services, the department funds a lot of our services. In fact, they provide 41% of our budget. So the family advocate position that we have, this person's job is to help family members locate resources and navigate the system.
And she's bilingual.
And she is bilingual, yes. Yes. And so I just wanted to say that if you know people who are looking for help, Gracie Huerta is our staff person whose task is to sit with people. Many times people just need someone to talk to, because having a loved one that has a serious mental illness is very overwhelming and scary, especially in the beginning. But then it's the hunt to decide what services will work and where you can get in, and that's not easy. So I just wanted to say that we hear all the time, I had no idea, I didn't know you were here, didn't know you would help, and we're free. We don't charge anything for our services. So I just wanted to say that if you can help us with that, that would be a very appreciated task. That's my presentation. Thank you. Yeah.
This is a question that I was going to ask the last group, but I'm going to just make a statement.
Okay.
Okay, okay. A few years ago, I brought this up at a forum about taking the land out near Goleta that was a drive-in movie theater, an old drive-in movie theater that was defunct, and then it came back to life, and I think it's defunct again, but I'm not sure, but I think it is. And turn that into a mobile home park for the homeless, where they would have laundry service, and there would be a manager, and it would be run by the city or the county, and they would pay a minimum amount of rent, and would be part of a community. There would be a playground for the children, and it would be a community, because we have so many people that are sleeping in their cars and sleeping in mobile homes all around the community, and it would just be, I think it would be a wonderful way to get people together, and it's just a suggestion. Thanks.
I would just add, creative housing solutions is a theme that we talk about a lot around homelessness, and so I think all types of housing solutions should be on the table. There have been some really interesting projects around the country using mobile homes and tiny houses, and, people need choice, and, some people are going to fit in better into a complex with lots of units and lots of other people, and some people need something a little bit different. So I think it's a good idea. Any other questions right now? Then I'll introduce our next speaker, Chuck Flax, who has some ties to this League of Women Voters of Santa Barbara through Mickey Flax there. And he's the executive director of the Central Coast Collaborative on Homelessness, and gets to work with a whole lot of these county departments and nonprofits on looking for solutions to addressing both the number of people experiencing homelessness in our community, and also the impacts that homelessness has in our community. Thank you, Chuck.
He's going to he's going to wrap everything up that we said and bring it all together.
That's right. So, hello, I'm Chuck Flax, and yes, I'm the son of Mickey and Dick Flax. Yay! Came back to Santa Barbara and took this job on back in May. But Santa Barbara actually has a very long tradition of trying to solve the problem of homelessness. And actually, when I was in college, I was an intern for Chuck Blitz, who's actually one of the leading philanthropists around homelessness. And back then, the problem seemed like a temporary one. And in fact, what got created, and to some extent still exists in Santa Barbara and elsewhere, are a network of temporary type services where we provide a certain amount of assistance, and then the hope is that people will get back up on their feet and they'll move on, and we'll be able to essentially solve the problem gradually, or get people to a place where they can be helped. And unfortunately, this has not been successful nationally, and there's been a real sea change in the problem of homelessness, and I'm going to get to that. There are kind of three things I'm going to talk about. First, who C3H is. Secondly, the issue around data and who the homeless are to some extent. And then finally, collaboration, which is what I was alluding to now. First of all, C3H, the Central Coast Collaborative on Homelessness, grew up out of a lot of different collaboratives that were going on, including the 10-year plan to end homelessness, which I think we're now close to the 10th year, and I'm not sure anything has really been implemented that was recommended in the 10-year plan. However, C3H itself is exciting on several fronts. First of all, we have a policy council made up of all elected officials sitting quarterly, actually every other month, to hear the issues around homelessness. They currently don't have a lot of power in and of it themselves, but they're all elected officials here in the county. So 2 county supervisors, Steve Lavagnino and Doreen Farr, I'm not going to name them all, but then 8 other city council members, including Mayor Helene Schneider, Council Member Dale Francisco, and Mayor Paula Perotti in Goleta. And they are very focused, particularly when they're meeting with us, on trying to find solutions to ending homelessness. And that's an exciting opportunity for people like you who are engaged in social issues to know that there are actual politicians who make it their business to really try to end homelessness in Santa Barbara. And that's really why I took the job, because I see an opportunity in that body to make some significant change. The other thing that's going on that's kind of exciting is my colleague Jeff Schaefer has been active in homelessness for a long time, and he works closely with Emily. And they work on the ground with folks that are here, as well as the kind of the foot soldiers or the different organizations that exist in different regions. And we're currently working in 7 regions in the county, representing everywhere except the most rural areas, forming groups that get together on a monthly basis to talk about strategies to end homelessness amongst their different communities. And it's very organic. Jeff is in many ways a community organizer. We're not allowed to do direct service. That's not our role. What we do is serve as a backbone organization to implement strategies. And right now, our biggest successes are in these regional strategies to really do what we can to bring different people and pieces to bear. So working closely with KUCO and ADMHS to try to get more outreach to reach out. There was a question specifically about this, to reach out to the chronically homeless who happen to have mental illness or drug addiction. In addition, working with nonprofit organizations who are providing direct service to people who are homeless to try to figure out their capacity and expand their role. Working with Emily on really targeting the most vulnerable and trying to find ways to offer them services even when they say they don't want them, at least in the initial stage. A couple of points on who the homeless are. It turns out so every 2 years, Emily's organization, Common Ground, has led what's called a point-in-time count. And this is actually a federally mandated process. Some of you may have participated in this. We had something like 500 volunteers around the county. And we counted both sheltered and unsheltered homeless. And that total was about 1,500. And it's been relatively consistent in the 3 times that we've conducted that count. Some changes that we've seen is that there's an increasing number of counted homeless people who are chronically homeless single adults in Santa Maria, and that increased by about 20%. And Santa Maria often thinks of itself as primarily a place where there are homeless families, but increasingly there are more people who are chronic and living in their cars, living on the street. Part of the reason there's been improvement, I think, in Santa Barbara is you have a high concentration of services like mental wellness, like Transition House, Casa Esperanza, et cetera, the Rescue Mission, Salvation Army, where people can actually go. And they show up in our count, but they're provided avenues to get out of homelessness. And so we're trying to really expand the kinds of services that exist for homeless people around the county. The other interesting fact that I saw in our data is that 64% self-identify as having mental illness. So clearly people are aware that they're struggling. And that one of the difficulties ADMHS has is it's tough to get someone into services if they're not willing to come. And so one of the things that we've been working with Common Ground is you essentially offer services every 2 weeks to these people. That's sort of the national model now is you say, look, we want to help you and check in with them every 2 weeks. And so that's leading me to this discussion of the sea change. There are communities around the country, the state of Utah, for example, and the city of Salt Lake, the state of Connecticut. I think Virginia just announced that they've ended veteran homelessness. When these states and cities are saying they end homelessness, they don't mean literally that everyone's housed. What they mean is that they've actually stopped the growth, or they've matched the growth of homelessness with the number of people that they can actually place into permanent housing. And the strategy that's working, and you may have read about this even today's LA Times, is housing first. And the idea is take people regardless of where they are, regardless of their drug addictions, regardless of their demons and mental health issues, and get them immediately into housing. And the results have been phenomenal. I mean, you see tremendous turnaround in terms of use of emergency services and use of the PUF, and we're at $1,800 a day, crisis calls, emergency rooms in hospitals. You can actually start to get people into the medical home that Dr. Wada talked about. And unfortunately, I mean, I'm going to kind of air our dirty laundry a little bit. Unfortunately, in Santa Barbara County, there's been a real resistance to this. And I think part of it is that many providers, in order to get their conditional use permits within their communities, in order to satisfy the neighbors and satisfy their funders, have had to really limit who they see to people that are really wanting to be helped and people who are willing to say that they're going to go for sobriety. And so there's virtually nowhere for people to go with the exception of the Rescue Mission, and even there they have a policy, you shouldn't be visibly intoxicated. if you have significant alcohol or drug problems, to be able to go and get placed and starting to move towards housing. And we currently don't have a real housing first strategy, with the exception of Pescadero Lofts, actually, where we're placing people immediately into housing and giving them supportive services immediately. What Common Ground and C3H are testing to some extent is this housing first strategy, first on Milpas Street and now on State Street, with very committed groups of volunteers. Again, some of you may have participated. I know Sharon Byrne was one of the leaders of this, where we were really saying to folks, look, we've identified that you're someone who is in real need of services. We'd like to help you. We would like to give you housing. And we've had an impact. I think the first 10 that were identified on Milpas, 9 have been housed. And we're in the process of gathering data to try to understand the impact that that's had. You know, are we seeing a reduction that you've seen in these other communities? And we're pretty excited about it. There was something else I wanted to say about that. Anyway, so Emily is a great point of contact on this. It's something that we're continuing. Maybe this is what I was going to say. We're so confident that we're able to organize these small groups of volunteers and service providers that I'm actually bringing on another staff member who's going to be full-time, who's going to be working. He's well known to the community, but I haven't hired him yet, so I'm not going to say who he is. But he's very skilled and knows this process very well, and we're going to be bringing him on board in Santa Barbara so Jeff can move up to Santa Maria and Lompoc and start to replicate some of this process up there. This issue around housing first is complicated severely by the fact that we just don't have any place to put people. So in the communities where it's actually worked most successfully, they have housing stock that's either vacant or with the mortgage crisis and all these issues, they have a lot of available housing. That's our biggest obstacle here in Santa Barbara, is finding places to put folks. And so that's something that, again, that we're working on. The issue of governance is one where, again, I think the League may be of some interest. There may be some of you who actually want to get more involved. C3H was started the idea, the germination of C3H is pretty old. What's more recent is HUD has mandated that in order to use their funding, and their funding is not a huge amount of money, it's about $2.7 million for Santa Barbara County. But it comes with the strings attached that you have to be doing housing first, that you have to be counting your homeless people, you have to be coordinating around data. And there's been some resistance in our community to really start to change the mechanisms for how we do homeless services. So I'm actually making a fairly bold proposal. When I came on board, there was something called the coordinating committee that C3H had that involved some of the people here at this table. And there was this thing called the Continuum of Care, which is involved, it's a separate agency, and it was involved in this HUD funding. HUD is saying, and these continuums of care exist all around the country. There's something like 700 of them nationally. That's the lens by which these communities have had the success they've had, is through the continuum of care. And HUD is saying broaden that, broaden the membership, include organizations like the League of Women Voters, include businesses who've been very instrumental in our success on Milpas Street, include law enforcement, include government agencies, not just the providers who are the beneficiaries of these public dollars, but a broader coalition of people who can inform how we do this and make sure that it's being done successfully. And I think that sort of freshening of how our approach here in Santa Barbara can have a pretty big impact. That was the pitch I gave when I got hired. I found out that, in fact, it's been difficult to make that happen, which was why there was this separate coordinating committee. My bold proposal is, let me do what I'm proposing, which is let's bring the C3H and the Continuum of Care together, and I'm actually making that pitch to my policy council next month. And then in January, there's going to be a public meeting where the policy council and the Continuum of Care will meet to try to hash out what could potentially be a problem, although on the other hand, maybe people agree with this vision that we can do more if we collaborate more. And the reason why I know this is, for example, in San Diego, where they've expanded their Continuum of Care, there's actually a funders collaborative made up of private foundations and philanthropists who have raised about $13 million in San Diego just to fight homelessness. And I'm sure that's much more significant than the HUD funding that they get in San Diego. In San Luis Obispo, where they also have a larger Continuum of Care, there's a program called 50 Now, and San Luis Obispo's Board of Supervisors is much more conservative than ours. They put forward a program where they allocated $1.2 million for 3 years, which is not a lot, really, to house 50 people. They originally said 50 people. They've already reached over 40, I think, and so they're thinking now that it may be even 50 a year that they end up housing. The money went to an organization that also operates here in San Diego called Transitions Mental Health, which has a strong housing component in San Luis. And the key component that really was successful there is the county said, we're going to guarantee 50 housing vouchers for homeless people to this program. And so they've identified vulnerable people, they're placing them in housing, they're giving them a housing voucher, and that's how they've been able to be so successful up in San Luis. We'd like to see a similar program like that here. So as Emily pointed out, there's a lot of ideas, there's a lot of energy, we have political will, we have very committed government officials and nonprofits. So the question is, why haven't we finished it? Why haven't we solved it yet? And I think the thing that keeps coming back is this shortage of housing. So we're going to blame it on my mother. I think it's really her fault. Blame it on HUD, okay. But I'm excited to be in Santa Barbara. I'm excited about this work. I actually think it's a good time in terms of all the different prevailing winds to be really addressing the problem of homelessness. And we're hearing of these success stories around the country where people are actually solving it. So with that, I'll open it up to questions.
I was wondering what percentage of the homeless are veterans, and is the federal government doing anything about it?
That's a great question. So veterans are actually the #1 priority of the federal government, veteran homeless. And there's a mandate by HUD, and the call has been taken up by Mayor Schneider and many mayors around the country to eliminate veteran homelessness by the end of 2016. In Santa Barbara County, there are approximately, and it's a count we're kind of working on, it's approximately 200 to 300 veterans. So that seems like a doable number. That seems like something we could really take care of. And we've seen some exciting results. The providers of housing and the people who work on this issue with the people who are homeless are housing about 20 veterans a month. So theoretically, in 10 months, we could potentially solve it. And we're engaged in something called a Homes for Heroes campaign in collaboration with Common Ground and with New Beginnings, which is actually they're the primary recipient of Veterans Affairs funding to support veterans. This Home for Heroes campaign is targeting landlords to say, look, when you're renting your place, consider a homeless veteran and we'll help you provide whatever support is needed to get them housed. Social Venture Partners is engaged in something called a landlord liaison program, where they're working directly with landlords. They're targeting veterans as well as their first priority to place veterans in housing. So again, a lot of energy around this. And then something that people don't know is that Section 8, which people hear a lot about, and they hear about the long waiting lists and people not being able to get Section 8 vouchers. Well, the Veteran Affairs Department has put aside a chunk of money called Veteran Affairs Supportive Housing, and it acts like a Section 8 certificate, which means it pays the market rate rent, regardless of what the veteran, what he or she makes. And those are interestingly very available. There's something like 30 of them currently available. And unfortunately in the county, I've heard stories of people with VASH vouchers not able to find a landlord willing to accept the VASH voucher. So that's really a crime, in my opinion. There's an opportunity here to house homeless veterans, to house any veteran who has a VASH voucher. So thank you for asking that, because that is one of our top priorities.
And if you do know a landlord, if they go to the c3homes.org website, there at the top, you'll see a word landlord. You can refer them to that, and they can be connected with Chuck to talk about how they can, provide units to veterans and to other, individuals, families, however they want to help, there's a way, that they can help.
You know, I think that question is a lot more powerful than you think, because I've been in conversations where people who have a strong opposition to helping homeless, who blame homeless people, the minute the conversation shifts and say, you know, do you know how many veterans are homeless, their whole perspective shifts. And I think it's important to continue to not segregate those two things, because, again, you have, Supervisor Lavanino, extremely supportive of veterans issues and homeless issues. And it's not, from his kind of political leanings, it wouldn't be what you would think. But they're supportive because of that realization. So I think it's a really important question, but it's also an important thing to highlight when you are trying to shift kind of people's political will and position on things, because they don't realize that a significant number of these folks are not just, that they include veterans, and I think people forget that.
And I would be,
Oh, no, I was just going to say, the thing that I'd like to add to that is that people often don't recognize that there's a lot of homeless people who are veterans that have a mental health disability that don't want to acknowledge their service. They had a bad experience when they were discharged, or they have PTSD and they don't want to acknowledge their service. And so we have a lot of people who come to the Fellowship Club. We just had a Veterans Day lunch, and a lot of people who said, I was in the service, but I don't want to be known as a veteran. And that's just a reality, and people need to recognize that that happens too.
And to just add to that, especially women, they've done some research that if asked, are you a veteran, sometimes the answer will be no, because the way a veteran is identified is, maybe, an image of a World War II veteran. But if you ask, have you served in the military, that's a way to elicit more information. But women veterans especially sometimes don't connect with the services that they could.
I have a question here for Chuck. You kept talking about the partnership of continuum of care with your organization, and you speak of it as an entity. Can you elaborate?
Yeah. So it's very strange. HUD created these continuums of care as a separate place where they fund counties. And the county can decide, and it's a little unclear as to who makes that decision without the continuum of care being well organized. The county can decide how it wants to organize the continuum of care. So essentially, it's anybody interested, it's really very broad, in the continuum of care comes to a meeting, you create a charter, you elect a board, and that's an independent organization that is in charge. It has two primary responsibilities: doing the consolidated application to HUD for the HUD funding for homelessness, and monitoring and maintaining the homeless management information system, which is the database that houses all the people who are affected by the funds that HUD has. That's at a minimum. And for many years, that's all we had in Santa Barbara. We had a small group of providers, largely, and some government officials who have been overseeing this process. I'm not saying they've done anything wrong, but it's just it's a conduit by which people get the funding and do the HMIS system. The new thinking around continuums of care is, let's broaden it to include all of these different stakeholders and start to examine, and HUD is actually slowly but surely mandating this. They're reducing any funding that's available for emergency services or shelters. They're really focusing on permanent supportive housing. They're requiring that all the dollars be leveraged significantly by other community resources. They want to see a broader participation. They want to see planning. They want to see better data than just the people affected by the HUD programs. So there's a real mandate, at least at the federal level, to expand the role of the continuum of care. And so I'm seizing that opportunity and hoping that I can convince enough people that this is important to really get a broader participation. And it's in terms of a collaborative, the Central Coast Collaborative, what's missing in this notion of collaboration is the inclusion of a broader array of partners.
We're going to take, I think, just maybe two more questions.
The last thing I just wanted to point out, and I'd be remiss, I meant to say this. A key component that we at the Central Coast Collaborative are not looking at, and what is frequently left out of discussions of homelessness, is that there's, according to the school districts, probably 100,000 kids countywide who are considered homeless by the schools. And this gets at the point, Kuko sort of said it quietly. He alluded to the fact that there's huge numbers of people that aren't being served by our systems. And these aren't just undocumented people. These are people who live in overcrowded conditions and do whatever they can to survive in Santa Barbara. The school districts have taken it upon themselves to actually call these kids homeless. And so it'll be very interesting in the next few years as I start to unpack this, to what extent there's services that can support those families. And I'll be looking to my partners here for that as well.
And Chuck wasn't part of the initial formation of C3H. But I know Emily was there. Several of us had significant issues in how, this was supposed to be a collaborative on homelessness.
Not 100,000, 10,000.
But homelessness was narrowly defined. And, so if you lived in a garage, you weren't homeless.
Right.
By early definitions, and that those kids that they're talking about live in substandard housing situations. So the school district or county office of ed looks at a different definition. So even standardization of how we look, and more importantly, when we do that, how it disproportionately affects populations by ethnicity. Just something as simple as how we qualify something. And again, what I point out is that for some cultural groups, it is not abnormal to live in communal housing situations. I grew up with relatives that I didn't even know I had who showed up, and guess what? You got a roommate. Now there's 4 of you in one room. And because of that, then, because we define it a certain way, then you know what? You're not homeless, even though there's 15 people living in a 2-bedroom apartment. So, but if you're
10,000, not 100,000.
but if you're couch surfing, you are homeless.
Right.
So again, thank you for
The definitions do cause all sorts of issues, and there was an interesting article I read that said, look at how, if you're addressing homelessness, one thing you could do is look at how other people who are very low income, who are housed, are, surviving and coping, and communal housing is one of the ways of doing that.
All of these things are interrelated. When we have in the city of Santa Barbara or on the South Coast a vacancy rate that approaches 0, where are you going to put people who are supposed to be housed first? There is no place for them. In traditionally HUD finance public housing, addicts are not allowed. So there have to be, even those, and both the city and the county have more than 5,000 people on waiting lists. And the VASH program, it's true, there were landlords who would not take VASH vouchers. We don't have, and in the general Section 8 program, there are landlords who will not take them. So the old line of the first solution, the main solution, perhaps the only solution to homelessness is housing. And until and unless we get the housing built, or enough people get out of their houses so we can use them, or we get apartments built, even for the workforce, building apartments for the workforce will free up garages or other housing that would then be available. All of it is related. So when Mr. Francisco comes to City Council yesterday and wants to close the door on the AUD program, the unit density program, the program by which the city decided in its general plan to have higher density small units downtown with only parking for 1 car per unit, he wants to put an end to that program. Well, it seems to me he has, a mouth with 2 sides. So we should all keep in mind that when you hear anything about housing being built, even if your particular interest is not housing, but say mental health or other social services, that is what makes the other things possible. And even worse, if you don't have the housing, it makes the other things impossible.
Yes. So, yes.
Nikki
So I
Fox gets the last word.
want to thank our speakers, and before I hand the microphone back to Amanda, just in our pilot project for the downtown area, just a few weeks ago, less than 2 weeks now, we had a man move into a unit, and he'd been homeless in Santa Barbara for more than a dozen years, very visible in the downtown area. And when he moved into his unit, he got rid of his long trench coat, he cut his hair, and he said, "This is my place." But one thing, and he's furnished it, beautifully, and, many volunteers have wrapped around him to bring him things that he needs for his unit. But one thing that's been the most amazing thing to watch is that this person who really didn't want to engage with mental health services has now done an assessment with mental health, has gone to CARES, which is the clinic in town, is now being considered for a higher level of mental health services. And recently, when he was at a nonprofit, Catholic Charities, so that he could connect with some food services, he disclosed that he had a mental illness on his own. And it's just been really amazing to see that happen. And I think that really that safe, place, the housing that he has, really opened that up to be possible. And also, of course, having the support and, the people there, to make that all happen when he did say he was ready for that help. So thank you all for being here. And I'm going to give Amanda the microphone for some closing comments.
Thank you, Emily, and thank you to all our speakers. Wonderful information, and we will continue to work with you as much as we can to keep these things moving forward. They're obviously so important. And Emily's story is just so graphic and so rewarding when you think about how that can actually help. So thank you all.